Welcome to my show, Dr. Dicken. You provide such a wonderful service for women and families. Let's start with tell us a little bit about you and what was the catalyst to get into fertility medicine?
Sure. Well, it's great to be here, Lisa. Thanks for having me. I'm really happy to be able to talk about my field of medicine. So, I went to medical school having no idea what field I wanted to go into. And to be honest, I had this phenomenal lecture my second year of medical school about infertility and treatments that were being done. And I had never heard about this before, right? In my 20s in medical school and did not know anything about fertility treatment or how common infertility was. And I just loved it and decided that's what I wanted to do.
Did anyone in particular inspire you?
Yeah, Yeah, well, so from that lecture, it was actually through, I was at the Albert Einstein School of Medicine in the Bronx, which is affiliated with Montefiore Hospital. And so the subdivision of the OBGYN group there that specializes in infertility were my mentors. That's who I learned from in medical school and who inspired me. I actually left that institution and trained in general OBGYN because that's sort of the pathway to get to infertility treatment. So I trained in general OBGYN at Columbia, had a great training, and then went back to my mentors at Montefiore and trained with them for an additional 3 years to be able to subspecialize as an infertility specialist.
You have such a terrific background and you're really well known out here on Long Island. I love how you give yourself to service and you're so authentic and real with your patients. And that's the real human connection that's made and established. So, the topic I'd like to start off with today is PCOS. For those
Mm-hmm.
who don't know, tell us what it is.
Sure. PCOS stands for polycystic ovarian syndrome. It's a very common diagnosis among young reproductive aged women. It's actually a diagnosis of exclusion. So that means that while there are criteria that women must meet to get the diagnosis, we have to rule out other reasons why they may have those symptoms. Most often, PCOS is going to be thought about for a woman who is having irregular periods. Okay. And an irregular period may mean not getting a period or getting a period once every few months, but it could also be just having a bit of a long cycle. Maybe your cycles are 35 days, 37 days, 40 days. And so that kind of prompts us to investigate why a woman is having either unpredictable ovulation or just very delayed ovulation. And so with PCOS, if we rule out other reasons why a woman's cycle is irregular, then the criteria that they must meet is they need to have either polycystic appearing ovaries on sonogram, which doesn't mean there are large cysts on the ovaries. It actually means that there are a lot of small little follicles that are basically small cysts. People call it like a string of pearls kind of appearance. So a lot of women think they have to have these large cysts. That's not the case. But polycystic appearing ovaries on sonogram, evidence of elevated androgens. So androgens are what we would think of as like male hormones, testosterone, things like that. But all women have them, just much lower levels than men. But when those levels are elevated from a normal female range, it can be part of PCOS. And so we can detect that in the blood, or some women will have kind of like clinical manifestations of this, meaning they have maybe a slight male pattern of hair growth, unwanted facial hair, hair on their lower belly, things of that nature. So that's the second criteria. And then the third is just the irregular cycles, right? So women have to have two out of the three, and we have to rule out other reasons why they would have those symptoms. And then they get the diagnosis of PC.
Got it. What are some of the strategies you do to work with your patients to reduce PCOS? What are the main ways?
So it really depends on whether a woman is looking to get pregnant or not. Honestly, the best thing that a young woman can do if she has PCOS and she's not interested in getting pregnant right away is to go on a birth control pill. Going on a birth control pill will regulate the cycle. It will also help to lower the amount of those androgens in the blood. And so it will help to get rid of some of the symptoms that go along with that. So a birth control pill is the best option for women who are not looking to get pregnant. If it's not sufficient for some of the abnormal hair growth, there are other treatments that can help with that. But I would typically start off with a birth control pill. Often that is the most helpful thing. That plus weight loss. So I know in general, it's challenging to lose weight for everybody, but especially women with PCOS. And I hear it all the time from my patients that they do everything right. They exercise, they watch their diet, and they just can't lose the weight. And it just keeps coming on. And it's challenging. But basically, a woman with PCOS, her body doesn't process sugar and carbohydrates well. And so women with PCOS should try their best to follow almost like a diabetic diet, low carb, low sugar, to try to lose the weight. The weight loss, even just like 5 pounds, can adjust the hormones in the body and sometimes help them to improve their ovulation. If a woman is looking to get pregnant and has PCOS, obviously we're not putting them on a birth control pill. And so then it really depends on what her symptoms are from PCOS. If the way I look at PCOS and how it typically affects fertility, sort of twofold. Number one is the impact of, for lack of a better term, the hormonal imbalance in the body and how that can affect the quality of the egg. So there are strategies to work on that. And then there's also the ovulatory dysfunction. So if a woman wants to get pregnant and has PCOS and either does not ovulate because of the PCOS or has a very unpredictable ovulation and just has difficulty knowing when she's ovulating, there are medications that we use to help with that. They are actually oral medications that can help women to grow an egg when their body doesn't necessarily grow the egg and ovulate naturally.
You touched a little bit upon it, the PCOS diet for a woman who is trying to conceive. What would you recommend?
Low carbs, low carb, sugar, lots of lean protein, vegetables, anything that's going to reduce inflammation in the body. Antioxidants can be helpful, but really is the difficulty with the body controlling sugar, right? So we know women with PCOS are going to be more prone to diabetes and insulin resistance. And when their bodies are working extra hard to control sugar and to process sugar and to prevent them from becoming diabetic, they are pumping out insulin. And the precursor to insulin, this insulin-like growth factor, is really not great for the quality of the egg. So when their body is making all of this extra insulin, it can compromise the percentage of eggs that are good enough to result in pregnancy. So the more that a woman can do on her own with lifestyle changes and diet modification and exercise to help her body to process sugar better by just ingesting less of it, is going to help the quality of the eggs. Separately, sometimes there are supplements that can be helpful. One that I tend to recommend for my patients with PCOS is myo-inositol. I tell my patients there is no magical pill, there is no magical vitamin that's out there, but myo-inositol may be helpful for egg quality in women with PCOS. There is a diabetes medication called metformin that we also recommend for some women with PCOS if their bodies are showing signs that they're having trouble processing sugar, if they're insulin resistant. Sometimes using the metformin to help their body to not work so hard is going to be helpful in them getting pregnant, and it can also lower the risk of miscarriage.
Great information, jam-packed with such golden nuggets for PCOS. Now, March was Endometriosis Awareness Month. I would be remiss if I didn't ask you about it and its importance. What is it for those who don't know?
So endometriosis, very simply, is when the tissue that naturally lines the cavity of the uterus is found anywhere outside of the uterine cavity. Most commonly, it is found in the pelvis, so around the ligaments that kind of secure the uterus to the bones and around the tubes and the ovaries, but honestly, it could be anywhere in the body. And I will tell you that any woman who walks through my door telling me that she's having trouble getting pregnant, I'm always thinking about the possibility of endometriosis because it is so common among women having trouble getting pregnant.
Yes. It's amazing how the stats are starting to rise. Why is it underdiagnosed?
So the textbook presentation, the way that we think about endometriosis is women having these very, very painful periods with debilitating pain that really impacts their quality of life, chronic pelvic pain. That's kind of like the textbook presentation of endometriosis. But the reality of it is that that's not how all women present with endometriosis. Endometriosis is a difficult diagnosis. Number one, because it presents differently in all women. Number two, because the only way to make the diagnosis 100% is with surgery. And so rarely are we putting women through an invasive surgery just to say, yeah, there it is, you have endometriosis. A large percentage of women with unexplained infertility have endometriosis and don't know it. I think the statistic that I last saw is about a third of women with unexplained infertility probably have endometriosis. Some people might call it a silent endometriosis, or it's just not surgically diagnosed, right? You can't see it on sonogram, you can't see it with a blood test, but there's probably some degree of it. And then when we think about, well, how is it affecting fertility? Again, can be different for all women, and there are a variety of ways. And what I tend to see is that it can affect certainly egg quality. And we know it can be more challenging for women with endometriosis to get pregnant. It can affect the quantity of eggs. So that we can test for pretty easily, right? With sonogram, blood work for a particular hormone level, we can get a very good idea of a woman's egg quantity. So if a young woman that I would expect to have a lot of eggs has a diminished reserve, meaning fewer eggs than I would expect. Again, it's sending up little red flags for me. Why is her ovarian reserve low? Could there be some process like endometriosis going on in her pelvis that we're just not aware of? Endometriosis can cause scarring in the pelvis. So some women, their tubes can be blocked because of endometriosis. And then another way that it can affect fertility, which is a really tough one to diagnose, is the impact it has on the uterus, right? And not specifically how thick the uterine lining gets, but more so like on a molecular level, when an embryo needs to communicate with that lining for a healthy implantation, women with endometriosis, in my opinion, have more trouble with this. Also, if endometriosis kind of infiltrates into the muscle of the uterus, that's when it's called adenomyosis. Those women tend to have more difficulty with a healthy implantation as well.
The impact of it is so huge.
It is, and it's, I will tell you, it's a very frustrating disease for patients and doctors alike. It is a tough one to address.
Can you improve it with exercise?
That is difficult to say. I would say that, yeah, in terms of pain and discomfort from it, probably. Yes. From a fertility standpoint, I think that exercise overall helps with fertility in general. I can't say specifically that it's going to change how endometriosis is affecting a woman's fertility, but I think that anything that a woman can do to kind of take away stress from a very stressful situation can be helpful. And I think exercise is great for that.
Let's talk about egg freezing. It's a hot topic. A lot of younger women are considering it.
Yeah.
And they want to bank their eggs just in case they decide to have a family down the road. Why should one consider it?
So as little girls, we are born with our eggs. We don't make more eggs in our lifetime. And thankfully, when we're young, we lose the eggs very, very slowly. It's very gradual, but that picks up as we get older. So it becomes a little more difficult to get pregnant as we get older, not just because we have fewer eggs, but we also have a lower percentage of good quality eggs, right? So it's almost like a double whammy, right? When women are in their mid to late 30s and start coming in, because they're having trouble getting pregnant, I typically have fewer eggs to work with and a lower percentage of good eggs to work with. So if a woman is able to preserve younger eggs, they are just more likely to be good quality and to result in successful pregnancy. Now, I think egg freezing is a wonderful technology that we have now. For sure, I would encourage young women to do this if they have the means, or certainly if they have insurance that's going to cover it. But I think it's also important when young women are doing this type of treatment to understand what it means to have frozen eggs. It is not a guarantee that you get a baby from the frozen eggs. It is not a guarantee that you even need those eggs, because the testing that we do before a woman freezes her eggs does not tell me if she's going to have an easy or hard time getting pregnant. It's basically just banking away some eggs in case she has trouble getting pregnant. And then I have more eggs and some younger eggs to work with if the eggs she has at that present age are not working for her. And the other thing that I tell all of my patients who are interested in egg freezing, right? Human reproduction is very inefficient. What I mean by that, it's not like one egg means one baby. It could take, even for women who are young, 10, 12, maybe 15 eggs in hopes of just having one baby. So when we are freezing eggs, we want to freeze a lot of eggs. Each individual egg does not give very good odds of having a baby. But if I have 10 to 15, I would say at minimum, that's typically what I'm looking for when I freeze eggs. I'm pretty confident, never a guarantee, but pretty confident that that woman hopefully would have one baby from that.
Exactly. And all it takes is one good egg, right?
It only takes one good egg, absolutely.
So for those who are not familiar with the process, can you talk us through from start to finish?
Yeah, absolutely. So initially, before a woman would go through an egg freezing treatment cycle, we start off with testing, which is very simple to do. It's basically just blood work and a sonogram. And that helps us to get an idea of that individual woman's egg reserve, right? Meaning quantity. And then for the doctor who's treating her, that helps us to come up with a protocol, the proper medications, the proper dosages. Now, I think it's important for women to understand the medications that we have, these fertility medications that we use, do not make eggs appear that aren't there. So if, for example, at the start of a menstrual cycle, there's the ability for 10 eggs to grow, even with a super high dose of medication, I can't get more than those 10 eggs typically. I can't make eggs appear that aren't already there. So we do this initial testing to get a good idea of how many eggs we may be able to get from a single treatment cycle. We come up with a protocol, and then most treatment cycles are going to begin at the onset of a menstrual cycle, which is when a woman begins her period, bleeding from her period. That is when there's a certain number of eggs in both ovaries that are ready to grow. Now, every month, a woman has a certain number of eggs ready to grow in her ovaries. And in a natural cycle, for a woman who ovulates regularly, her body typically grows one egg and she loses all the others. So when I am prescribing these medications at the start of a menstrual cycle, I'm basically giving a stronger stimulus of what the body naturally makes to get those other eggs to grow. So I'm rescuing eggs that she would have naturally lost in that cycle. Okay, so the fertility medications that we use to get these eggs to grow are injectable medications. They are very small needles, subcutaneous, so it just goes right under the skin. Most women are able to give themselves the injections just in their lower belly. But I would say, depending on the protocol, it's typically 2 and then up to 3 injections daily for about 10 days. So it's an intense treatment for that 1.5 to 2 weeks, but then they're done. They're using these medications daily and they're coming in frequently to be checked. We call it a monitoring. So they come in for blood work and sonograms so that we can see how their body is responding. We tweak and make adjustments in the medications as necessary. And we're trying to determine when the majority of eggs have grown to the point that they're ready to come out of the ovaries. So when we think the majority of eggs are ready, we have a woman use a final medication. Some people call this the trigger shot, which basically begins the maturation process for the eggs. And then we do a procedure in the office that we call an egg retrieval. So this egg retrieval takes place, I would say, about 2 weeks after she started the injections. It is a procedure, it is not surgery, but it is done with anesthesia. Otherwise, it would just be very uncomfortable for a woman. The anesthesia is just a deep sedation, similar to what someone would get for like an endoscopy or a colonoscopy. And the procedure itself only takes maybe 10 or 15 minutes. It's pretty quick. It is all done vaginally. So no incisions, no cuts, no scars anywhere on the body. And what we are doing during an egg retrieval is draining the follicles, which are like these special cysts in the ovaries where the eggs grow. There should be an egg in each follicle. So it's actually really cool because our procedure room is connected to our IVF laboratory. So when I look on sonogram and I see the follicles and I drain the follicles, I can't actually see an egg. So what I see is the follicle collapses, all the fluid came out, goes into a test tube, and that tube gets passed right through a window to the IVF lab where my embryologist is sitting with a microscope and is talking to me during the procedure to let me know whether or not I'm getting eggs out of the follicles. So it's a lot of really cool technology so that we can actually know that we're getting the eggs from the ovaries. Now, what a woman does to freeze her eggs is actually no different than what a woman does for IVF. The difference is what we do with the eggs once we have them in the laboratory. So with a treatment cycle where the plan is to freeze the eggs, what we do is we assess all of the eggs that we got. And what we're looking for is signs that the egg is mature, meaning it's ready to fertilize. But instead of fertilizing it, we freeze it.
Mm-hmm.
Okay. And so many of my patients will ask me, well, how long can I keep it frozen? Does it matter? There really is no expiration date, right? Whether we freeze and thaw an egg a month later or a year later or 5 years later, the likelihood of it resulting in a successful fertilization and a healthy embryo and pregnancy will be no different. What really predicts that is the age of the woman when we get the eggs from the ovaries. And that all has to do with our female biology and the quality of the eggs based on our age.
So important. How can one prepare for egg freezing?
I think that, certainly having a good support system is important because I think more so than like the physical toll on the body, there's a lot of emotion that goes along with any kind of fertility treatment. So I think a good support system is really, really important. In terms of, diet and whatnot, I just tell my patients really a healthy diet. You don't need to cut out everything that you love. A well-balanced diets rich in antioxidants are always good for the eggs, reducing inflammation, moderate exercise, just being active and being healthy. You do not need to cut out all of the caffeine that you like to drink. One small cup of coffee is okay in pregnancy. So it's okay if you're, going through fertility treatment. Alcohol in moderation is okay. 1-2 drinks spread out across the week while you're going through treatment doesn't affect anything that we do.
Male fertility is in crises. Stats out there show that sperm has decreased 50%. What is your take on this?
I think that data that's out there is really difficult to understand, to be honest. I've seen it and I've read recent articles about it. This data about sperm quality and sperm concentration declining in men has been reported since studies in the 90s that were looking at sperm counts from men in the 50s. So to be honest, I kind of take the data with a grain of salt. I think the studies that were done don't necessarily all have the same group of men in it, so it's not comparing apples to apples. I'm sure there are lifestyle factors that affect sperm, just like there
Hmm.
are lifestyle factors that are affecting eggs, right? We
Hmm.
worry about, some of the environmental toxins and our diet now and obesity and underlying medical issues and how that can affect quality. Um, I think that people are more aware of fertility now. And so people who maybe are getting their sperm counts checked, it can bias the data. Um, we've always known that male factor infertility plays a big part in a couple's infertility. It's
Hmm.
not all about the woman and the egg. The
Exactly.
sperm play a major part in this, and it's estimated that probably close to a third of couples have some male factor component. In my experience, it's rare that there's just one specific factor that's causing the couple to have trouble conceiving. I think that there's some parts that are a female component, some parts that are male. So in general, I mean, I'm always thinking about the male components, and I don't think that the data that's out there necessarily changes what we do.
Good to know. So, switching gears, I like to ask all my guests what kind of things you like to do for self-care. I know that you're very busy, but my audience would love to know what you like to do to de-stress and get grounded.
That is a great question. I certainly am busy. It's tough. I am balancing home and work life. I have two young kids and a very active puppy at home.
Oh.
So I am busy at home and at work. I enjoy playing tennis, and I do that once a week, so that's a good outlet for me. I really enjoy spending time with my husband and my family and just, kind of de-stressing by going out and doing things that we enjoy doing. It sounds a little funny, but I love to like curl up with like a good cup of coffee and do a crossword puzzle, and it just makes me relax. Like I'm just not thinking about anything else for those, 15, 20 minutes, and it helps me to relax. Uh, yeah, I guess
I
that's
love
pretty
it.
much what I do.
It sounds like you have such a great routine that keeps you grounded and a great support system. So, if you wanted one thing for our listeners to take away from our conversation today, what would it be?
I would say, for anybody who is either struggling to get pregnant or considering fertility preservation, I wouldn't be nervous about coming to see an infertility specialist. At least what I like to do with all of my patients, we work as a team. We figure out what works best for you, what you're ready to do, and how can I kind of help you to achieve your goals. And nothing that we do is really scary or difficult. I think the most common thing I hear from my patients who wind up going through treatment is it wasn't as bad as they thought it would be. So I think what I'd love people to kind of take away from this is it is not scary and not difficult to kind of start a fertility journey. I think most women that I speak with are pretty relieved after that initial appointment and just getting a plan in place and just learning more. I find that one common theme I hear from all my patients is, we spend so much time when we're younger learning how to prevent pregnancy, and nobody teaches us what it's going to be like when we're trying, and how each time you have unprotected intercourse, you're not guaranteed a pregnancy. And now, especially here in the Northeast, when careers kind of play into when women are ready to start having a family, it affects the likelihood of conceiving, because what our bodies are biologically meant to do is not necessarily corresponding with what our society is now more interested in. So again, I like for patients to come in and just feel comfortable and know that we're working together as a team.
Great words of wisdom for our listeners. Where can our audience get in contact with you, and what is your preferred social media?
So I am working at RMA New York, Long Island. I am in the Melville office. So they can certainly reach out to me there if they're interested in coming in for a consultation. I do my best to post occasionally on social media. I do have an Instagram. It's Dr. Cary Dicken. And I try to post, some little bits of information about, I actually did one recently about endometriosis. So I try to get my patients and everybody else out there some factual information, because
So
you got to be
important.
careful what you
Yes.
Google. You definitely have to be careful what you read out there.
Exactly. Be aware of Dr. Google. I'll
Dr.
be sure to include all of your information in our show notes. I am so grateful to have you on today, Dr. Dicken. Such a pleasure to connect with you.
Really nice to meet you and to chat today. Thanks, Lisa.
My pleasure.